Go then. There you go. Once we do our initial orientation to the organization here by me now, we'll start with a keynote address by a distinguished pair of collaborators whose work together I think really embodies the theme of this assembly. We're then excited to offer a workshop put on by our research committee entitled Making an Impact with Your Research, which will discuss research methods in global surgery. And then after a short break, we'll return for a panel discussion in academic collaborations for system strengthening before closing out with a few next steps and some upcoming events. During the sessions, we invite everyone to really please communicate with the speakers during those sessions and each other by asking questions through the chat. And we want to really make this a fun and interactive 3 hours. Next. All right, so we all know that academic global surgery, it really involves the application of research, education, and evidence-based advocacy towards clinical surgical care in regions of health inequities, and that's the idea of the field. The primary goal of it is infrastructure development through academic partnerships worldwide with the delivery of high-quality surgical care to all, regardless of location. The AAGS's role in this is really to organize and cultivate AGS programs, to promote bidirectional partnerships, and to develop the next generation of global surgery leaders worldwide. Currently, we offer 5 membership categories and 17 committees that aspire to really cover the range of individuals and issues critical to the current and future work in our field. Additionally, we hold biannual meetings, one in the spring and another one in the fall. We currently have 183 active and affiliate members, 129 associate members, and 126 student members for a total of 438 members across 47 countries and more than 100 institutions. Now, the AAGS came together around the idea, as I said, and the passion for developing, unifying, and advancing academic global surgery programs globally. While our first members and their programs were in North America, the aim from the beginning has really been for AAGS to be a global organization. We want to engage LMIC members and programs. However, we need your help with that to spread the word, to join, and to get involved in the work of the organization. We want everyone as part of the membership and the leadership of the organization. And I think therein, I'm excited to say that our next spring assembly will be held in an LMIC location in hybrid format. And additionally, we aim for 50% of our organizational leaders to be from LMICs by 2025. Today, and people are still logging on, but the assembly today's virtual assembly is host to 170 registrants from 31 countries. Of the individuals registered, 51% are women, more than half are in training or non-MDs, and almost a quarter are from non-surgical fields, including anesthesia, OB, emergency medicine, or in business or public health, all of whom are critical to the work we do. Our current committees really represent the work we aspire to do, and they're shown here. There's 17 of them as we talk about across a range of everything that represents global surgery. In the way of updates, we recently held a strategic planning leadership meeting to establish an initial kind of true north for the organization, to orient us to the large buckets of work we do and the stakeholders that we strive to serve. I want to specifically thank Circles International for facilitating that session, Operation Smile for financially sponsoring that work, and the entire Leadership Council who are here for their efforts in spearheading this initial strategic planning meeting. So the AAGS has begun kind of formal relationships with other organizations, including Incision and its national working group, GSSA, as well as the Global Surgery Working Group of the Research and Associate Society of the American College of Surgeons and Operation Smile, as I mentioned. Through these relationships, we've held a few events specifically aimed at bringing together leadership of programs with people coming into the field, students and trainees who are interested in global surgery. And then most recently, we presented a video abstract on AAGS and its purpose and this vision that we have for this during the 2022 conference of the Consortium of Universities in Global Health. There was a 10-minute video. It's available on our YouTube channel and will also be played during the break today. We're excited to really continue broadening these formal relationships across organizations throughout the world. Moving to today, I want to specifically call out the individuals who have made the content and the dissemination of today's programming possible. Drs. Nunez and Geisling from the Congress Committee, Drs. Chin and Nkamstra from the Research Committee, and Drs. Yap, Freitas, Ulhasan, and Tate from the Information Technology Committee. Thanks to all you guys for the hard work you put into this to give us this event today. So this really brings us to the real start of our program. I'm pleased to turn over the meeting to Dr. Jade Nunez, who's the chair of our Congress Committee, who's going to introduce our keynote speakers. Dr. Nunez is a trauma surgeon and faculty for the Center of Global Surgery at the University of Utah. He leads ongoing projects in Mongolia, which includes establishing an ATLS program, expanding rural laparoscopic courses, and building research capacity and assisting with national surgical planning. So Jay, take it from here.
Great, thanks so much, Jay. Thank you all for being here. This some work has gone into it, and so we're very excited to see you all. We have a pair of really exceptional keynote speakers today. Dr. Alain Chichom-Mefire is professor of general surgery based in a semi-rural area of the southwest region of Cameroon in Central and West Africa. He currently serves as the vice dean in charge of research and cooperation at the Faculty of Health Sciences at the University of Buea. Professor Chichom-Mefire has oriented his professional life toward contributing to surgical equity and global access to quality surgery and anesthesia. He's authored over 85 scientific articles, published in renowned peer-reviewed journals. His research work is focused on improving the care of the injured, standardizing the management of abdominal sepsis, advocating for the fight against antimicrobial resistance, and implementing surgical quality improvement programs with specific focuses on trauma. Professor Chichom-Mefire is a member of the International Society of Surgery. He's also serving as a representative for Africa in the International Association of Trauma Surgery and Intensive Care. He's a member of the Alliance for Surgery and Anesthesia Presence and the editorial board of the World Journal of Surgery. Additionally, he's co-director of the program for the advancement of surgical equity based out of UCLA. Dr. Chichom-Mefire, unfortunately, does not have electricity and therefore the internet, so he's trying to find access to the program. So hopefully he'll be joining us soon. His colleague, Dr. Catherine Juliard, is here to speak as well. She's a trauma surgeon and a critical care physician at the University of California, Los Angeles. She received her undergraduate degree from Stanford University and her medical degree from UCLA, where she also completed her general surgery residency program. Dr. Juliard went to UCSF for her fellowship training, where she was a trauma and critical care fellow at the San Francisco General Hospital. While on faculty there, she was director of the Center for Global Surgical Studies and the San Francisco Wraparound Project before she was recruited to UCLA in 2018. She's currently the co-director for the program for the advancement of surgical equity. Her primary research in global surgery seeks to improve access for quality surgical care in low and middle income countries, primarily through a long-standing NIH-funded partnership with the University of Buea in Cameroon. And it looks like Dr. Chichom-Mefire has made it. Thank you so much, and please take it away.
Thank you so much, Dr. Nunez. I am going to attempt to share my screen, so if it doesn't work, everyone let me know. Okay, 1 second. How's that look? Everyone okay?
That's good.
All right, great. So hello, everybody. And on behalf of myself and Dr. Chichom-Mefire, who against all odds made it today, which I'm really grateful for, I'd like to thank the AAGS and all of you for the opportunity to speak today. It's a huge honor, and I've noted multiple visionaries in global surgery joining us. Doctors Tarpley and DeVries, Price and Wren, all of you have mentored me at one point or another. So I know, thank you for coming, and it's great to see you all. Here are disclosures. A lot of these are both Dr. Chichom and mine together. We are or now it's called MPIs on multiple grants that have allowed us to do some of this work. Today, we're going to talk about the academic surgical model. I'm going to focus my part of this presentation on surgical societies and the partnerships that can come from that and how they can influence systems level strengthening for surgical care. And Dr. Chichom will then speak about institutional level partnerships and focus on a project that our institutions worked on together as an example. And then I'll give a few recommendations for systems level strengthening. This is a picture of Dr. Chichom and I about, 10 or 12 years ago when we were both younger and more relaxed, I guess. I don't know. Academic surgery is often described in terms of three core skills: excellent clinical care of patients, scientific research, and educating future surgeons. A true academic surgeon is often spoken of as a triple threat, someone who can do all of these things. And accordingly, the mission of academic surgery is often spoken of in terms of these core areas as well. Even at the institutional or societal levels, you'll often see these core tenets in Department of Surgery's mission statements, for instance. Surgeons tend to be a little rigid in their definition of what's academic. So today I'm going to build off of this model and probably stretch it a little and add to it to hopefully convince you, although I feel like I'm preaching to the choir here, of some of the key ways that academic societies can have meaningful impact on surgical system strengthening in multiple settings. First of all, sometimes the true strengths of academic institutions lie in the overlapping areas of these three classic academic surgical pillars. And for instance, if you look at the intersection of research and education, there's scientific training, including training in research methods, grantsmanship, and scientific writing. Academic associations are really well positioned to intervene here. And a great example of this is the scientific research training course that was created through a partnership of the Association for Academic Surgery and the West African College of Surgeons. I saw Dr. Nuome join this conference, and I'm going to use his work here as an example. The concept for this course was developed by Dr. Ben Nuome, who is a pediatric surgeon. Most of you probably heard of him. He's the director of global surgery program at Ohio State and also the pediatric surgery fellowship program director. At the time, Dr. Fiema Nwariaku, who many of you may have also heard of, was the president of the Association for Academic Surgery. And the two of them got together and thought that a truly effective surgical research methods course should be able to be implemented anywhere in the world, even in the lowest income countries. At that time, they looked up the least wealthy country in the world based on the World Bank Human Development Index in 2008, which at that time was Sierra Leone. That year, the annual West African College of Surgeons, or WACS, meeting was scheduled to occur in Freetown. Under the leadership of Drs. Nuome and Nwariaku, the AAS, in partnership with WACS, launched their first course on the fundamentals of surgical research and career development. At that time, 10 faculty delivered the course, many of whom were from the AAS. And at the time of the course, the Minister of Health in Sierra Leone said that there were, quote, as many surgeons in this room, end quote, as there were at the time in the country of Sierra Leone with a population of 6 million people. So there was great need for development of surgical care. After that meeting, they took it on the road. It's been given in Liberia, Nigeria, Ghana, and over that time, there was increasing transition of leadership and teaching responsibilities from the AAS to WACS. And this course ultimately got absorbed into a pre-existing WACS research course and helped strengthen it. It's now known as the West African College of Surgeons Research Methodology course. This group has published their experience and in the 10-year evaluation. The course demonstrated an average attendance of about 67 people, and on one occasion they had as many as 120. And the US faculty used to deliver the course has gone down over those years. It used to be about almost all 10 faculty, and now it's about 2 who are from the US. And it's all under WAC's leadership. And I chose this example because I really think it demonstrates the true capacity building, longevity, and ultimately the sustainability that can be achieved through surgical society collaborations. And I think these things, longevity and sustainability, are also key hallmarks of good academic work. One of the benefits of working at the institutional or societal level is the longevity afforded by the institutions themselves. They outlive any one of us, which allows for sustained efforts towards big goals over time. And if the efforts are successful, they can be institutionalized and ultimately become sustainable through the institutions themselves. And I think these concepts are really at the core of health system strengthening. Societies and institutions are set up to make systemic change. They outlive individuals and can form professional bonds between people and institutions that are essentially pre-codified and legitimized. That allows individuals to get a running start on projects as they join the effort, coming in under the auspices of an established institution, and then leapfrog into the productive phase of professional relationships. And then there's an opportunity to pass work along to the next person, building towards sustainable platform, and that can be supported more durably by the institution itself. The AAS is a great example of this. The organization has an inherent agility, I think, due to the relative youth, if you can call it that, for surgeons at the end of our training of their membership. Among US organizations, they and the SUS, I think, have arguably been vanguards in recognizing the academic nature of global surgical work and then leveraging these institutional partnerships to help achieve their surgical missions. Here's Dr. Nwome's timeline and a number of initiatives the AAS has led over the last 15 years to help strengthen their investment in global surgery. Without an institution supporting this over time, allowing these initiatives to build on each other, it's really hard to imagine such sustained and effective engagement. One of the initiatives that the AAS invested in, and we're really pioneers in codifying, and that many of you may be very familiar with, is the AAS Global Surgery Resident Research Grant. And this was initially, when it first started, a $10,000 stipend to support a US-based general surgery research resident to do a mentored global surgery research project. In its lifetime, this relatively small amount of funding had such an impact on the field of global surgery. It allowed emerging global surgery stars to get their footing and produce relatively high impact research for the size of the funding. So the AAS Foundation actually voted to increase the award amount to be on par with its other sibling resident research awards, which demonstrates a real investment in academic global surgery development. Okay, coming back to this model, we've just spoken a little bit about how surgical societies can have sustained impact at the intersection of research and education. Another area to consider is the intersection of education and clinical care. Often in global surgery, we think of capacity building and clinical care as being done at the individual or small group or even hospital level. But surgical societies have had a long track record in the United States of developing high impact coursework at the institutional and national levels. Some examples of this are the impact that courses like ATLS have had on the standardization of trauma care in the US. And I think we can do a better job of thinking about the scope of the target community for these courses. And to do that, I'll give an example based on our team's experience in Cameroon. Our group currently has a 4-hospital multi-center trauma registry that's about to actually get expanded to 10 hospitals next month. That served as a data source for several projects aimed at trauma system strengthening. My amazing research partner, Dr. Chichom-Mefire, is going to speak more on the potential impact of institutional academic partnerships on health system strengthening later on. But I just want to give one small example that illustrates the need and the potential real world impact courses like ATLS can have in global surgery. Okay, as part of a quality improvement initiative that we were fortunate enough to get an NIH R21 grant to implement in Cameroon, A soon-to-be former mentee of mine, Dr. Ariane Christie, who's going to be finishing her trauma fellowship this June, used the multi-institutional Cameroon Trauma Registry to analyze the deaths of 183 trauma patients who were living on arrival to the emergency ward, but then later died. Dr. Christie found that the vast majority of trauma non-survivors presented with one or more clinical abnormalities on primary survey, and she broke these down by the ATLS primary survey resuscitation categories we all know and love: A, airway; B, breathing; C, circulation; and D, disability. And she found that there were inconsistencies around the frequency of diagnostic or therapeutic interventions done in response to the abnormalities that were identified. Although Dr. Christie did this for each category, I'll just briefly mention the B problems as an example. The B problems are breathing problems, and they occurred in 63% of trauma non-survivors. Of these, some good things happened, like 60% received supplemental oxygen, and despite the numerous barriers to obtaining radiology studies in this context, 14% were evaluated with a chest X-ray. But very few received interventions to correct these abnormalities, such as needle decompression or chest tubes when they seem to be indicated. And this is really interesting. Our group found this interesting because these interventions are often life-saving and potentially can be implemented in a low-cost fashion. Protocolized trauma training like ATLS to solve this problem was not only identified in Dr. Christie's trauma registry analysis, where she concluded that having some protocolized trauma training would help correct this issue, but it was also independently identified as a QI target in our QI program's trauma QI committee, which was comprised of providers from each of the Cameroon Trauma Registry hospitals who came together and reviewed trauma deaths and trauma complications on a quarterly basis for 2 years. And they, in their summary meeting, identified this also as an issue. So we had our quantitative data from our trauma registry and our peer review process aligning on these recommendations. In Dr. Christie's conclusions to her research, she highlighted that improving access to validated training programs like ATLS could dramatically decrease trauma mortality in LMICs. Historically, there have been several barriers to wider accessibility of ATLS, and one of these, in addition to the cost and the difficulty of implementation, is the pervasive thought in the past that ATLS isn't context appropriate for LMICs. And I would say, of course it's not. It's not even context appropriate for most of the US. It's really designed for the rural, under-resourced, and lone hospital-based emergency provider. But we implement it as a training protocol in almost every single trauma center that engages with trauma patients in the United States. And we trust our learners to think about how to implement this in their own environment, because it's the principles that matter. It's the principles of ATLS that we trust people to understand and to implement appropriately. I would argue we should be able to do the same for our LMIC counterparts and allow them to decide what's context appropriate and to implement the principles as they see fit in their environment. I think while courses like ATLS really highlight the power of surgical societies have to impact health systems on a broader scale, I think there's a continuing opportunity to better consider the broader trauma community that these powerful products could be serving. This course is sponsored by the AAST, which is the American Association for the Surgery of Trauma and probably the largest US-based trauma organization, and ESTES, which is the European Society for Trauma and Emergency Surgery. And it's a little more accessible. It's $200 and has a virtual option, so that also increases its potential reach. Courses like PTC are also really great resources for trauma care training. And some courses increase accessibility to LMIC surgeons and partners through scholarships or tiered pricing, which are great efforts that should be supported and further expanded. I think our US-based societies should consider to try and expand all of these opportunities. And there is hope. The AAST lately the American College of Surgeons Committee on Trauma lately has been thinking about how to further include equity issues, including global surgery, social determinants of health, and trauma-informed care in the next edition of ATLS. I was actually asked to help write the injury prevention chapter on that, and the person who asked me specifically said that my work in global surgery would help bring a different lens to that they were now really looking for. The American College of Surgeons also has a new working group that's called the Improved Social Determinants to Attenuate Violence Working Group that is really emphasizing health equity issues. And while this is still US-based in its focus, it's a promising step for health equity everywhere and really expands beyond what the traditional scope of the American Colleges of Surgeons focus has been in terms of trauma. So this is also an exciting initiative. Okay, so a lot of the things I've been focusing on here are the things that academics, as essentially nerds, including academic surgeons, are traditionally supposed to be good at: research, methods, teaching, evaluation. And these things largely map to our old model of the academic surgical triple threat. But I would argue that we are good at more than that. We're good at advocacy. Surgeons like Rochelle Dicker and Joe Saccharin have made their careers based on their highly effective advocacy for things like hospital-based violence intervention programs and gun control, respectively. We can also be good at partnership when we put our minds to it. Now, I'm not saying everybody, surgeons will be surgeons, as we all know, but we're used to working in teams, and the best of us understand that it takes many different types of people working together to get big things done. All of these aspects, the expansion beyond the triple threat, are the essential components of strengthening a healthcare system if you bring them all together. And we actually have a history of doing this very effectively in the United States. So this, I'm not making this up. This is rooted in experience of our profession. So advocacy and partnership. In conjunction with the other academic pillars, US surgeons and scientists have done this before. In 1966, a group comprised of the Committee on Trauma and the Committee on Shock, which were part of the division, oh, my screen just went dark. Okay, sorry, which were part of the Division of Medical Sciences in the National Academy of Sciences National Research Council, so all academics, published something called Accidental Death and Disability, the Neglected Disease of Modern Society. Does that sound familiar? Neglected disease. Global surgery has been called by one, you may have heard of him, Paul Farmer, this. So they were dealing with the neglected disease of trauma in the United States. Among other things, they advocated for funding, education, and research initiatives to address trauma and injury, including partnership between the medical fields and local and national government, highlighting the need for government leadership on this issue. This group successfully argued their case, and Congress responded by passing the National Highway Safety Act of 1966. This was largely seen as the first step in trauma center and system regionalization and organization in the United States. And since then, there's been an ongoing, sustained, and very successful effort to continue to strengthen US trauma systems, largely through academic and government partnership and advocacy led by physicians and scientists. Interestingly, something that was advocated for back in that first report is the establishment of a National Institute of Trauma within the Public Health Service, and that still has not happened. Which brings me to another priority that surgical societies need to champion to help support systems level change: funding. The Coalition for National Trauma Research in the US is leading the latest charge in our country to advocate for a National Institute for Trauma to be included within the National Institutes of Health. And you can see here Drs. Chris Kokenor from UC Davis and Dr. Eric Lay from Cedars Hospital in Los Angeles, here with one of our California congressional delegates, Doris Matsui, to advocate for the development of a National Trauma Research and Action Plan. This organization actually has an advocacy toolkit available on their website to help US trauma surgeons and researchers support this effort. The Fogarty International Center, although one of the least well-funded of the NIH branches, has been ahead of the curve on this. They have two funding mechanisms, an R21 two-year exploratory grant and a D43, which is a trauma training grant, that are dedicated to trauma-related programs and research in LMICs. Funding priorities, as we all have seen, shape national priorities, whether it's in a high-income country, the United States, or in a lower middle-income country like Cameroon. And we've seen this play out before with the example of PEPFAR and what happened with the impact on HIV research and care. So surgical societies have an opportunity to really coalesce around these efforts to help leverage them more effectively and get increased funding for trauma and other surgical disease-specific research, both at the national and international level. And this takes leadership, this takes organization and numbers, and all of these things surgical societies have. I would also argue that with this advocacy comes a responsibility to organize training in grantsmanship, including scientific writing, grant application processes, and grants administration. For anyone who has tried to apply to a federal grant in the United States, it is alphabet soup. It is so confusing. But US federal funding is one of the most well-resourced pools of scientific funding in the world. Grantsmanship and grants administration experience are often the true hurdles to independent investigator funding, both for the US and LMIC researchers. The HIV research community has figured this out. The NIH actually has a training grant dedicated to helping LMIC institutions increase their research administration capacity. It's called a G11 External Associates Research Development Award. While focusing our societal efforts towards more trauma and surgical disease federal funding, we need to have some parallel efforts, I think, to increase these grants administrative training opportunities. Until those things happen, in the meantime, we can also potentially work on using surgical societies to provide courses in a similar model to the AAS WACS research course on grants administration, grant writing, how to use NIH Assist. If any of you have ever tried to use that platform, it's extremely difficult. And other critical skills to independently obtain federal funding to unlock this really rich resource to support scientific work. There are many, many other examples of how surgical societies can help influence surgical system strengthening that we don't have time for today. So I'll leave you with a few priorities that I came to in thinking about this talk. First, advocacy for further disease-specific funding, like we just spoke about, for neglected surgical diseases like trauma at the federal level in the US. And these efforts should be made towards not only funding for the US, but funding for LMIC surgical disease research. High-income country surgical societies can also explore ways they can support their LMIC partners and sisters organizations in their local advocacy efforts as well. Society-level investment in existing promising programs should be strengthened. Successful global surgery research grant programs for US trainees like the AAS Global Surgery Research Award should consider having increased reciprocity, where LMIC trainees get funded and maybe even offered co-mentorship if they want it. Existing international scientist travel grants, perhaps we could consider increasing the number and scope of these grants to specifically sponsor LMIC surgeon scientists. The AAST International Relations Committee has a nice model of a program where they just started under the leadership of Mark DeMoya and Rochelle Dicker. They've created a mentoring program with funding for attending a meeting by an LMIC mentee to attend the AAST annual meeting and present their work there after they have a mentored research program experience. Strengthening formal liaisons between high-income countries and LMIC partner societies like WACS and ACS and enriching these links with more resources would be a great idea. The ACS has a representative to WACS. It's a single person, but it would be great to give a little more strength to that relationship and see what can come of that, that powerful partnership. And finally, investment in research capacity building, including grantsmanship and administrative skills for LMIC institutions, would really be a great investment to help unlock this rich resource of federal funding for scientific research. Okay, so back to this model. I focused on a big picture, somewhat theoretical and potentially boring overview on how I think surgical societies can build on this age-old model of the academic surgical triple threat to help strengthen surgical systems in both the US and LMIC partners. I'm now going to turn it over to my partner, Dr. Chichom, who will focus on this third intersection between clinical care and research by taking a deeper dive into our real life experience on how institutional level partnerships can contribute to surgical system strengthening. Thank you so much for your attention this morning or evening, depending on where you are. And I will welcome now Dr. Chichom-Mefire.
Thank you. Can someone hear me?
Yes.
Great. Thank you. Thanks very much. Thanks for that great presentation, Catherine. Someone is sharing a screen right now.
Diseases. So we're going to have to explain to people in correct medical terms and in sound.
And make sure that, yeah, everyone.
Something is wrong. Okay, great. Thank you. Thanks very much. It's so exciting to be part of this. I think I know a number of people on board right here. I think about Ben Wome, we've met before during an AAS meeting. I think about Teresa Shin. I think we shared a panel as well recently in an event which was all about global and academic surgery. Hi, Teresa. Hi, everyone. It's really a big honor for me to be here on board. Let me start sharing my screen. Here we go. Can we see my screen? Great. I sometimes have an issue when sharing screen. When I go full screen, my slides cannot change anymore. So I will run them from here. I think Dr. Jade Nunez introduced me better than I would have done it myself. I just want to indicate here that I'm a member of a number of societies, among which the AAS. And I see a number of people on board here who are members of AAS and who are, so it's all about academic surgery. For the next 10 to 12 minutes, if you don't mind, I'll take you for a trip in Cameroon through, now that Dr. Juliard completed the discussion about collaboration at the society level, I will take you into an institutional partnership between two institutions from two completely different backgrounds, and try to demonstrate to you how this can be game changing. The example I'm going to take is the example of the trauma quality improvement program that we just completed running in Cameroon. When you look at my disclosures, that you probably wonder why they are pretty much the same with Dr. Julia. The reason is simple. We don't get any funding for research in Cameroon. If you need funding for research, you will have to move to NIH or to Fogati International or whatever situation. So I will take you for that trip in 3 points. I'll first tell you about the background and the situation in Cameroon prior to the beginning of the institutional collaboration between Los Angeles and Boya. Then I will tell you what we've achieved within the framework of this collaboration. And finally, in a few words, I will tell you how we see the future and what it's all about. This is where I come from, Cameroon. It's a country located in the central and west Africa region of the Africa continent. It's actually a poor country. We consider ourselves, we are classified by World Bank as a middle income country. I don't want to comment on the GDP per capita, 26 million people. And in Cameroon, if you live 57 years, you are quite lucky. You should consider that you've got a good life. You can't compare with anything that is happening elsewhere in developed countries. So this is the country where I was called about 18 years ago as a young surgeon to come and take care of the surgical problems of people located in a semi-rural semi-urban or semi-rural area in Cameroon. And the first thing that is striking when you get to a level 3 institution in Cameroon is you are first of all totally impressed by the fact that 80% of people who show up in the hospital come for an emergency situation. You begin to wonder, but where are the elective cases? You will understand the reason in a minute. The second thing is that among these emergency cases, injuries alone represent between 50 and 55% of all of them. And you quickly understand that it actually happens mostly on the road, and that motorcycles have a very great role to play into it. So based on these basic observations, you feel like trying to dig a little bit deeper in understanding the problem of injuries. You first go worldwide and you realize we're talking about 6 million deaths every year, but that a number of you know. But what is even more shocking is the number of disabled, 650 million people. And I'm giving you here figures which are as old as 2004. The situation has moved forward. Then you learn that more than 90% of cases are actually coming from low and middle income countries. You want to dig more into the specific situation where you are. So you go into Africa, then you learn that you have 78 million people living with a form of disability, which is injury related. It's shocking, but that's not all. Because nothing is being done at the moment, the projections are that by 2035, and we are almost there, is we're going to make it 125 million people who live with a form of disability and who need rehabilitations. Now, you already know it's happening in the road. It is at this point that you go into what data are available in the specific country. I'm talking about Cameroon, back to Cameroon. What do you have? Virtually nothing in terms of epidemiological data, which could help you estimate the magnitude and the details of the problem. Absolutely nothing. You have non-specific, or rather too specific literature on some particular aspects of injury. At that time, you get engaged in an academic career and you feel like you must take responsibility for doing something about this. The first step you want to take is get some baseline information. So you look at the registration system, because after all, WHO publishes figures about injuries in Cameroon. Where do they get that figures from? They actually get them from the administrative data. So we did actually a baseline assessment of the existing registration system to find out how reliable it was and have a first idea of what injury epidemiology is all about, but also about the pattern of injury, severity, and everything. And we ended up with a publication. Then we realized that at that time, there is someone somewhere who has the same interest, who is also assessing the current registration system. That's Dr. Juliard. And this is the opportunity to meet someone who is formidable. I apologize for the quality of the internet. The weather is crazy here. And when it happens, the internet connection is a mess. So you might miss some of what I'm going to say, but I will do everything to make sure that you get my message. So we have a health system in Cameroon, which is well structured, stratified in 5 levels, from the health center to the reference hospital. Issues that are considered in the Ministry of Public Health as major public health priorities are coordinated at the central level. I'm thinking about tuberculosis, HIV, AIDS, malaria. Then you realize there is nothing for the injured. You want to go and check, how can we compare? Actually, injuries kill more than these 3 public health problems combined. And now you have this big issue that we don't have a universal health coverage in Cameroon. You might not believe this, but this is the truth. For the most incredible services like blood transfusion, you have to pay some money, at least for the tests that are going to be conducted on the blood that you're going to get transfused with. So this makes me to think that decisions makers actually need guidance in the form of evidence that will make them understand that injuries is a priority. Then you want to tackle it from the academic angle as a surgeon. I agree with Dr. Juliard that the concept of academic surgery needs to evolve. We cannot still rely on the tripod that you know about, which is clinical care, research, and education, which kind of overlap in a number of areas. And we think that these areas where they overlap are actually critical for the action we want to implement. Then we look at the challenges. We have to face immediately the challenges of our local system, clinical care. We don't have standard, locally adapted guidelines and protocols. There is almost no culture of patient safety and quality of care. And nobody seems to be concerned about equitable access to surgical and anesthetic care. So we make these some of our priorities when it comes to clinical care. In terms of research, no need to tell you we don't have any funding specifically dedicated for medical research, or very little, non-focused, really completely disorganized. But we don't even seem to have a research plan which is oriented towards solving, identifying, and solving very specific problem. And obviously the clinical research infrastructure is extremely poor. And then you have challenges about education also. This is the classroom with my students who are here in their third year of medical education. We have a medical education system with an undergraduate system which is oriented towards solving the problems that are considered in Cameroon as priority. And I've listed some of them for you. They don't seem to take into account the fact that injuries are a problem. Then, as I said, you meet this beautiful lady, then you start thinking about establishing a partnership with the idea of joining efforts in identifying problems and solving them. So it's a strategic partnership. Both of us, as she said, in our early career, I wasn't this old at that time. So a trauma surgeon from UCLA and a general surgeon from University of Buea will come together. We were able to secure a very strong support from the Ministry of Public Health of Cameroon, and I think this really helped us. We had to create a specific organization. We started in San Francisco with the Center for Global Surgical Studies when we shifted to PACE, Program for the Advancement of Surgical Equity. You see that equity by that time has become a priority in our thinking. And we had two main goals. The first one was improving the care of the injured. We didn't focus much about preventive measures, primary preventive measures, but rather focusing on the care on the injured with the idea of coming out with conclusions that cannot be applied only in Cameroon, but also in all low and middle income countries with similar characteristics. Then we now have the focus on equity as well. And the idea is to try to bridge the gaps of inequities in access to surgical and anesthesia care. As soon as we started this collaboration sometime around 2009, the results were immediate. The first of these results is that we were able to implement an electronic trauma registry in 4 pilot centers in Cameroon. So from the manual registry I was running in Limbe, we had 4 pilot sites in Cameroon. We were able, and this was so important for us, to conduct a community-based analysis with all aspects of injury that we were able to address at the community level. And we immediately secured 2 NIH and Fogati international grants with the project we were able to write. One of them is about the capacity building focus on trauma, quality improvement, which I'm going to discuss with you in a minute. But before I get to that, I want you to take a tour about the situation of injury in Cameroon as identified from the 4 pilot trauma centers. These are the 4 centers you are seeing here. We were able to actually prospectively collect data on patients and their injury in 2 regions of Cameroon. In no time, we were able, at the date of today, we have data on over 25,000 victims of injury. We were able now to do a preliminary analysis and get information about demographics, the context, the clinical care practices, and even the outcomes. We have a clearer idea of what is happening in Cameroon. We also conducted the community-based survey, which permitted us to reach over 8,000 individuals after accessing more than 1,200 households. The figures which were published by WHO prior to this community-based study was about fatality rate of 28 per 100,000 population. In a community-based, which is a much stronger approach, we actually realize that it is 4-fold what WHO is reporting. So, and we confirm that it exceeds the rates for malaria, tuberculosis, and HIV combined, but that's not all. We realize that the care-seeking behavior, formal care is a problem. People don't always go to the hospital when they have a problem. They stay at home or they consult traditional bonus settlers, as we call them here. And the reason is obvious. They come to the hospital, they have to pay from their pocket and they don't have money. So they prefer to go back home. And the consequences are heavy. We have nearly 70% of people who are living in their homes with a significant trauma-related disability. And this was shocking to us. They are not capable of performing independent, basic life issues by themselves. So based on these findings, our R21 project was about establishing a trauma quality improvement program in Cameroon. So we wanted to build on the existing trauma registration system that we have developed to come out with a QI quality improvement methodology appropriate not only to Cameroon, but which we can actually generalize to other sub-Saharan African countries. We had 4 aims, and these 4 aims were actually driven by one main concern. It was sustainability. That's why we wanted to train 4 quality improvement fellows and 2 quality improvement program managers who by themselves would be able to establish quality improvement programs focusing on trauma in other institutions in Cameroon. And we also now were able to implement quality improvement committee meetings. During these meetings, we brought together a number of stakeholders from the 4 pilot institutions. I'm talking about medical doctors, traumatologists, and orthopedists, radiologists, nurses, hospital administrators, laboratory specialists, and everybody. We brought everybody with the idea of discussing about adverse events occurring during the process of management of a trauma. So we developed a tool to track adverse events, identify a number of adverse events, which we brought for discussion in the trauma quality improvement committee meetings. Initially, we were holding these meetings physically, but with the COVID-19 challenges, we had to shift to a more virtual approach. We were able to hold 7 of these meetings. We brought together between 18 and 25 participants each time and came out with a number of incredible conclusions, which we think can guide policy. The first unbelievable conclusion, really unbelievable, and I presented this to the Ministry of Health. We hope they take action based on what we shared with them. 80% of those who die in Cameroon, if things are done properly, and Dr. Juliard raised your attention on some of the things that are not being done properly. If things are done properly, 80% of those who die as a result of trauma in Cameroon are actually not supposed to die. They are actually preventable or potentially preventable. And when I say potentially preventable, it is based on low-cost measures that are easy to implement and which do not need the mobilization of major infrastructure or human resources. We're also able to come out with what kills most. People die because their brain got involved. And in our hospitals here, people still bleed to death. Some can't breathe, and we cannot intubate them or perform a tracheotomy for multiple reasons, which I'm going to take you through right now. We came out with 6 specific, and this is the result of the root cause analysis that we performed during our QI trauma improvement committee meetings. 6 correctable deficiencies, which we identified very clearly. The first one, Dr. Juliard talked about it, which is a major concern at all levels, is the lack of a structural approach, say ATLS or whatever else. But clearly there is a problem in how we approach the patient with an injury from the beginning of the management, from the initial management. We are letting traumatic brain injury patients die because we don't have neurosurgeons in all. For a population of 26 million people in Cameroon. We have 19 neurosurgeons, and all of them are actually focusing in the 2 main large cities. So in most places where you have traumatic brain injury patients, there is no neurosurgeon. And we have not been able so far to develop a protocol for the general practitioner and other first-line healthcare providers who are actually the ones taking care of these traumatic brain injuries. You have other issues like when a patient needs to be intubated, there is nobody here there who knows how to do that, even when the equipment is available. And I don't want to take you into the challenges obtaining blood transfusion and these kind of things. So you see, based on an academic approach to institutional collaboration, we were at least able to pick up the problems through a process that has been validated elsewhere. We know what the major problems are. From there, we start building towards the future. 3 sets of measures. Actually, Dr. Juliard and myself and our team, because we have a lot of people around us who are contributing massively to everything we are doing, we are still brainstorming on what to do with what we found. But I think for the future, we have at least 3 axes. The first one is we can develop immediate, low-cost, potentially life-saving interventions like training or continuous medical education of first-line healthcare providers on the initial management of the injured. This should be done easily. We're actually working on that. Dennis, one of our trainees who is presently with me here in Cameroon, is, I think, on this call. We're working together on coming out with something which we hope to be sustainable. We need to work on developing locally. It's not about taking guidelines that are applied in Los Angeles. It's about adapting them to make them context appropriate. Protocols, guidelines, and our number 1 focus is traumatic brain injuries. We're working on that right now. The second axis, which is more compatible with the spirit of sustainability, is I think I can take advantage of my faculty position as a vice dean to inspire a revision of syllabus of the undergraduate medical education to give injuries the focus that it deserves. It would be, for example, about making a complete course like ATLS a course that is mandatory. You can't graduate as a medical doctor in Cameroon if you've not validated the ATLS, and this is possible. I'm drafting a communication with the ministry in charge of higher education in Cameroon to do that. Then it's all about involving the Ministry of Public Health into all interventions and advocating for them to finally consider injuries as one of the injuries should be given the same level, at least the same level of priority as the other major public health problems that we have in Cameroon. You might have noticed that I left some space free under each of the set because I have a lot to add there. As I told you, we are still brainstorming. And obviously, we still need to continue into working within the framework of academic surgery in, first of all, gathering more evidence, that is securing more research funds. Anyone here who is able to guide us on getting more research funds is absolutely welcome, but our future is all about capacity building. Maybe I take this opportunity to let you guys know that there is hope here in Cameroon because Dr. Juliard and myself and a bunch of our collaborators just secured 2 major, still NIH and Fogati international grants. One of them, a U54, which is going to permit us to gather massive data about injury. We're going to shift our trauma registry in Cameroon, National Trauma Registry, from 4 centers to 10. We'll be able to gather data now and in thousands, and we will be able to use this data to run 2 projects. One of them about following up patients who have been discharged from the hospital, and the other one about developing a tool to assess, because I told you that equitable access is one of our focuses now. We want to develop a tool to measure socio-economic status, which we can share with all our African counterparts. The second project is a capacity building project, which we're going to use to train a bunch of trauma research collaborators who are going to be the basis for our future data center based in Boya. Thanks very much for listening. and I will be more than happy to share with you. Don't forget about this African ambulance. We've got a number of things that are better than this at the moment. Thanks very much for listening.
Well, thanks, Dr. Chichom and Dr. Juliard. Very inspiring, informative talks on really what's possible when individuals, institutions, and these societies, as you point out, prioritize and utilize academic collaborations to advance our surgical systems work. As we close the panel, we're going to turn our attention back toward kind of where we're at with the AAGS and a few next steps before we close, hopefully right on time. Thanks again. Let's see. Chris, you're up.
Kathy, would you mind sharing the slides? Perfect. So hi, everybody. I'm Chris Dodgen. I'm a trauma and acute care surgeon at the Medical College of Wisconsin, and I have the good fortune of serving as the current treasurer of AAGS. I just wanted to mention a couple things, things to look forward to. So please look forward to committee self-nominations opening in the fall of this year. Please consider self-nominating or nominating others with their consent for a position on one of our many committees. As mentioned by Dr. Krishnaswamy, we're aiming to have greater LMIC representation in our leadership, and this is a great way to go about getting that. There will be positions available for all the committees. For more information about the committees and their goals, please go to the link at the bottom of this page. It's a 2-year position with half of the members of the committees turning over on an annual basis, and it requires just a brief statement of interest. Please consider, again, that self-nomination process. We do need your ideas and leadership. That's how we're going to continue to move the work of this organization forward. And then finally, if you are new to the AAGS or your academic institution is new to AAGS, we're looking for 2 representatives to be the representation from your academic center to sit on our institutional representative council, who will help guide the goals and work of AAGS and our committees. Again, I think was mentioned earlier, we have over 100 institutions currently involved in AAGS. We've not gotten a complete representation from all of those institutions. If you are a member and would like to represent your institution, please reach out to the leadership and we'll get you involved in that representative council. You can see on this slide kind of how the representative council correlates with the membership and the leadership council, and how we kind of gain significant direction from that institutional council to guide us on what work we should be focusing on to strengthen all of our global collaborations and partnerships.
Thanks, Chris. So we're planning a fall assembly. We are planning semi-annual assemblies. Our fall assembly, we're hoping to be concurrent with the American College of Surgeons meeting. It will be in person and virtual. So we're looking for interactive or novel interactive approaches to a hybrid meeting. We are planning this to be more research focused, and we'll be accepting abstracts. We should have more information for you in the next month or so. And to reiterate, our goal is to have the spring assemblies in person and hybrid, and basically rotating continents. So we don't want to stay in the US or in North America. We want to be everywhere and to have a global membership and global leadership. I'm beyond excited as how this Congress has gone. I think there are ways we can improve, and I would personally love to hear from anyone that has ideas. So please email me with things you'd like to discuss, topics you'd like to touch on, and any approaches that come to mind. So thanks so much, everyone.
Hi, my name is Mamta Swaroop, and I'm a trauma critical care surgeon. I'm also the president-elect of the Association for Academic Global Surgery. And we wanted to remind everybody that as a reminder to join AAGS so we can continue to grow the organization and achieve more for advancing surgical care all around and together. We wanted to kind of review some of the membership benefits. As you can see today, we have people from all over the world, and we would like to continue to allow for more networking and collaboration with colleagues globally. We have programmatic development that occurs throughout the year. We also have biannual meetings, as you guys know and have just heard about. And we plan on having more webinars and workshops in person and virtual. So you can join AAGS through this bit.ly if you just copy paste this or just type this in. And also we have a QR code here that will easily allow you to join the organization.
So with that, hello again. I just wanted to thank everyone also for being here today with us, and we hope to see you at the Fall Assembly 2022. Here's our website, our email address that you can reach us through. Please follow us on social media. We are on Instagram and Twitter, and we would love to hear from you. And we have a YouTube channel that you can subscribe to, which is Association of Academic Global Surgery. Today's assembly is recorded and will be added to the YouTube channel as well. And there is a QR code again now for our entire website. With that, I'd like to pass the mic to Dr. Krishnaswamy.
I don't really have anything else to add. Thanks everyone for your participation, and hope everyone has a great rest of the day. Please fill out the post survey, and we look forward to seeing everybody as members of the committee, spreading the word, working together, and seeing each other again in person in the fall. Thank you.